Hi guys, I know there's going to be a lag, so I'm just waiting for everyone to join in. Okay, let us look at अभी स्ट्रीम स्टार्ट कर दिया, रिकॉर्डिंग भी स्टार्ट कर दी है। हाँ सर, अभी हो गया, ठीक है। We're just waiting for a few minutes. So while people join in, I hope you guys are doing well. And today I'm going to be taking an important topic, audiology. And as you all know, audiology is always confusing if you don't approach it in the right manner. तो आज जो मैंने आपके लिए slide deck बनाई है, it is made in such a way that it will be easy for you for a quick revision anytime. Okay, so it's not like I'm going to write too much, as already whatever I want to say is there on the slide deck, but I'm going to walk you through it so that it's easy and legitimate for you to read. मेरी handwriting बहुत खराब है, so that all these important points are put over here and you will be able to answer most of the questions related to audiology. I think the lag is quite a bit right now because I'm already been on for now more than a minute and it is not showing going live on the channel yet. तो ऐसा हो सकता है कि आप मुझसे कुछ सवाल पूछें and I will not react or respond for maybe even a couple of minutes long looking at this lag. But I will continue to teach, and whenever you have any questions, please put them in the chat window. This is the only way I will know if you are there and things are going fine. And then afterwards we can have a discussion on whatever topic you need. तो अभी तक stream नहीं हो रहा है. What is the problem? Like it's not playing or problem? Okay. Looks like it is just me and my tanhai today, so we'll not waste time and let me get started with what I want to teach you today. Regardless of whether you guys are there or not, you can always watch it later on. Okay, so there are a lot of questions that come from audiology, and one of the common problems that people have is that they get confused with the answers. So one is to understand the approach for audiology. Okay, so if you want to get all your tuning fork tests, or you want to hear get the entire hearing screening done in the right manner, you have to follow a particular sequence. अगर आप ये sequence नहीं follow करोगे तो फिर आपको लगेगा कि कहीं confusion हो रहा है, and most of the times we jump the gun. First thing is to identify side. Okay, the first thing to do is identify the side. This is the number one thing to do. And it's always easier to answer MCQs than to treat patients, because patients are not always telling the full information and हमको वो extract करना पड़ता है. But in a question paper, the examiner has to give you the right clues, the right keywords to help you get your answer right. So we have to know the side first, and they will mention it in the question: right-sided hearing loss, left-sided hearing loss. You have to register and document this. Then only you will know what it is when you go forward, because the second step is always Weber's. Okay, not Rinnes. We say Rinne Weber's, but in the sequence of when we are examining, we will do Weber's, because only when we do Weber's we will know that the side that the patient is having the problem with, is it conductive or is it sensorineural. If you do not know this at this point of time, then when you do Rinnes you will get very confused, because when you do Rinnes you will not know whether it is a true negative or a false negative. If it is negative, or if it is positive, what is the nature of it. And after this there is Rinnes, And then there are the other bone conduction, Quavax or Bing, Jelly, all of these things, they come after, but this is the sequence that you need to follow. The second thing that you need to do when you're doing any audiological examinations or testing is to understand what is the test being done for. Okay, so Weber's is a test of cochlear function, and Rinnes is a metric of your bone conduction or air bone conduction, basically. Okay, your conductive pathway in the middle ear bone conduction pathway. This is very important to understand, otherwise you will get confused. Now I'll explain to you how we do this. Okay, so air conduction tests for middle ear pathway and bone conduction tests are for cochlear pathway. So when you want to see the cochlear function, you're basically doing the bone conduction. Many times we think that अगर हम bone conduction के लिए test कर रहे हैं, then that is basically for the bony conductive pathway in the middle ear. No, it is basically vibrating the skull to directly trigger the cochlea. You're bypassing the middle ear pathway. Whereas air conduction, you are testing whether that middle ear pathway is working, because we have adapted our hearing for air, right? We were underwater earlier, now we have come to air. All our gills have become external ear structures, middle ear structures, and now we are adapted to hear sounds in air. So all your air conduction tests are basically testing the ossicular chain. All your bone conduction tests are actually testing your cochlear function. ये समझना बहुत ज़रूरी है, otherwise you will get confused and you will find audiology to be very, very difficult. Okay, so bone conduction test, sensory neural bone conduction should be reduced, and in conductive hearing loss, bone conduction should be prolonged or increased. All right. So now, tuning fork test. So I have a tuning fork with me, and this is a 512 hertz tuning fork. And 512 hertz tuning fork is the most optimal for hearing test, because there has optimal tone decay and it has the optimal speech frequency. इसका मतलब क्या है? So suppose if I use a 256 hertz, the lesser the frequency, the higher the amplitude. Okay, that's why bass is low amplitude, low frequency but very high amplitude, so it travels further. If you go to a rock concert, you will hear the drums and the bass from far away. You will hear the lead and the singers only when you get closer. Because higher the frequency, the lesser the distance it travels. तभी चीखने चिल्लाने से कुछ नहीं होता, आपकी आवाज़ दूर तक नहीं पहुँचेगी. But bassful वॉइस में अगर आप बात करोगे थोड़ा सा भी, then you are going to do better that way. All right. So 256 hertz tuning fork is low frequency but higher amplitude, so it is very good for neurological testing. So when you strike that and you put it on your on the bones, you can get good proprioception, vibration, and those kind of things. If you do 1024 wala, then that is high frequency, very low amplitude, so that is basically not going to travel much at all, so very short tone decay. But ये जो 512 hertz है, this is ideal because it has optimal speech frequency. This is the speech frequency when we talk is between 500 to 1000 kilohertz. Hertz. So we talk in that range. So this is in that speaking range, and it has optimal tone decay. मतलब it is once you strike it, it rings for long enough for you to do your assessment. Not so long या wait कर रहे हो कि एक test इतना लंबा चल रहा है, right? So that is the idea of choosing 512. Now Weber's, guys, Weber's is important. Again, you are testing cochlear function in Weber's. That is very important to understand. Now you have seen in the question what is the side that is involved, whether it is right side or left side. Now once you know, okay, there's the patient has right-sided hearing loss, you strike the tuning fork and you place it either somewhere in the middle over here or here, and then you see which side is this tuning fork going to lateralize. If it lateralizes this to the same side, then that is conductive hearing loss problem. So the same side of the complaint to the same side it has lateralized, that is a conductive hearing loss. If it lateralizes to the normal, then it could either be normal side or it could be a sensorineural hearing loss on the hearing loss side. And this is a very, very important thing to find out. So right-sided hearing loss, I don't know if it's conductive or sensorineural. Weber's lateralizes to the same side, that means वो conductive hearing loss है. There is a problem with the ossicular chain. And if it goes to the opposite side, then that means that right side has a sensorineural hearing loss. ऐसा क्यों होता है? What is the reason for this? What is happening? If you're going to understand it, you don't have to by heart it and remember it, and you will not get confused in the exams. See, what is this doing? We are basically striking the tuning fork, we are placing it on the skull bone right over here in the middle. So it is basically the vibrations are traveling from the skull, and these vibrations are going to go and shake the cochlea, because cochlea is also housed within the temporal bone, and then the fluid within the cochlea will move and the hearing will then go to the auditory cortex and you will perceive. So by doing this, you are completely bypassing the air conduction pathway, the ossicular pathway, and you are only triggering the bone and you are stimulating the cochlea on a particular side. अब क्या होता है, when right side is conductive hearing loss, there's a phenomenon that occurs that when you have conductive hearing loss, when you block your ear, you will feel conductive hearing loss. Now if you block your ear and see, outside sound is now masked, so your inside sounds, your own voice that you're talking will be louder. The same voice which I'm talking now without closing my ear, and the same thing which I'm talking after closing my ear, my sound is perceived louder to me when the external environment is closed. So when there is conductive hearing loss, there is ossicular problem, middle ear there's problem, then the sound is going to be appearing louder on the side where there is a conductive hearing loss because of that phenomenon. Okay, now suppose this right side was a sensory neural hearing loss. If it is a sensory neural hearing loss, then that means the cochlea on that side is damaged. Okay, there is a decreased cochlea function on that side. So what happens is, since you are conducting the bone, the other side cochlea is picking up the sound better, and that's why it lateralizes to the more normal cochlea or the normal ear because of that, and that's why right side you are not able to hear, because you are triggering the cochlear system. You're basically bypassing the ossicular system and you are doing bone conduction, so it goes to the cochlea. But either agar cochlear problem hai, hearing loss is sensory neural, it is not going to be able to hear, and the opposite side it will go, and that's why when it goes to the opposite side, it is a sensory neural problem. Similarly, if there is a conductive and sensory neural mixed component, then the Weber's gets a bit complex to understand. Wherever there is a higher conductive problem, it will lateralize to that same side, and wherever there is if there is a higher sensory neural problem, it will go to the opposite side. But when hearing loss is of both sides, you will not know which one was the actual conductive, ye same mein ja raha hai ya opposite mein ja raha hai, and that's why we need to also do the Rinnes test to get a little more clarity on now what is happening. Okay, because this is too convenient कि एक ही कान में problem है, so Weber's will give you quite a good answer, but अगर ऐसा होता नहीं है, most of the times hearing loss is a bilateral problem, and that is where you have to individually test the ear for its conductive ossicular chain as well as its bone cochlear chain. All right, so then what we do is we do the Rinnes test, and Rinnes test is a simple phenomenon that if you are putting the sound next to the ear, that is air conduction, and if you're putting the sound on the mastoid, that is bone conduction. Air conduction is testing the ossicular pathway, middle ear. Bone conduction is testing the cochlear function. Now in us humans, we have adopted for air conduction to be better than bone conduction. So if I strike this tuning fork and I place it on my mastoid bone, when I am able to stop hearing this, if I place it back near my ear, I should be able to hear the sound, because air conduction is better than bone conduction, and this is Rinnes positive. Okay, this is normal, or it can be seen in sensory neural hearing loss, because in sensory neural hearing loss also your air conduction will be better than bone conduction on that side. I'll explain to you why. But if this is a conductive hearing loss over here, there is the ossicular path is not going, then what will happen is, when I'm going to strike it, my bone conduction is going to work well, because my nerves are fine, cochlea is fine, hearing sensory neural part is fine. But when I bring it back over here, I'm not able to hear. So now you will actually know, after doing the Weber's, when both sides hearing loss is there, when you do Rinnes test, then you will know where the conductive deafness is and where there is normal or sensory neural deafness. But now there is a problem. If somebody has profound sensory neural hearing loss, profound sensory neural hearing loss means it is very, very severe and profound hearing loss. Let us say my right side has got profound sensory neural hearing loss. इसका मतलब ये होता है, if I strike and if I put it here, whatever I'm doing, the sensory neural hearing loss is so much that the cochlea is not taking any sound signal to the brain, whether I keep it here or whether I keep it here. But the skull is also connected to the cochlea on the opposite side. So what happens is when I strike this and I am placing it on the bone over here, I am able to hear a sound because the other side cochlea is transmitting the sound to me, and it will falsely tell me that the bone conduction is better than air conduction, even though कोई conduction इधर ठीक नहीं है. And that's why you will get a false negative in Rinnes when there is severe profound sensorineural hearing loss, because the opposite side cochlea is the one that is getting triggered. The other question जो बहुत बार audiology में पूछते हैं, that is what is the air-bone gap based on Rinnes. So I am doing a 512 hertz. This basically means if the air-bone gap, if somebody is not able to hear this, or bone conduction is better than air conduction, or Rinnes is negative, that means there is a 30 decibel air-bone gap. You need to have more than 20 decibel air-bone gap to say that it is a conductive pathology. Now if I take a 1024 hertz and that also में ये problem आ रहा है, that means there is more than 45 decibel air-bone gap. If I just take a 256 hertz in this 15 decibel air-bone gap, it's hard to tell whether it is a conductive or a sensorineural component. All right, so this question also is quite commonly asked. Whether yeah. Now, what is this absolute bone conduction? On absolute bone conduction, now you are again checking the sensorineural hearing loss of the patient and comparing it with the examiner. तो हम लोग ये सोच रहे हैं कि whether the examiner has the right hearing. We are assuming that the examiner has the normal hearing, and we're taking that as, you know, the marker for this. So what we do here is that in absolute bone conduction, we first strike the tuning fork, place it on the mastoid of the patient, and we close the tragus. Okay, we mask it, we close the tragus. Now when the patient is not able to hear this anymore, we place it back on our mastoid, and if we can hear it, that means our bone conduction is better than the patient's bone conduction. So if our bone conduction is better than patient's bone conduction, that means my cochlear function is better than the patient. So the patient has some sort of cochlear dysfunction or sensorineural hearing loss. That is the interpretation. So if the patient has a sensorineural hearing loss, then they are going to have a shorter hearing this thing, and the ABC is going to be shortened for them. But if they have normal hearing, then we will have equal, or if they have a conductive hearing loss, then they're going to be able to perceive conductive hearing loss, which is the ossicular chain hearing loss, like otosclerosis or something like that. They're going to be able to perceive it a little more louder than me, because of the phenomenon that when we close the ear canal, the sound is louder, right? So but still, if we're anyway closing it, right, so that's not much of a difference. But when you do the other test, like the Schwabach's test, in Schwabach's test you are not closing the ear canal. So when you are not closing the ear canal, here when you do it on somebody with otosclerosis, that time the patient will have a prolonged hearing of the sound compared to us, because his or her ear is as if it is closed, but yours is open and you're getting all the sounds from outside, right? So in an absolute bone conduction test, you're not going to see much of a difference or prolongation. But in Schwabach's test, you're going to see if somebody has an ossicular chain problem, then they are going to be able to perceive the sound for a longer period of time. If it is a cochlear problem, sensorineural hearing problem, it will be the same. They will hear lesser than you in that particular scenario. All right. Now, we've done what is a side by asking the patient or looking at the question. We have figured out through Weber's which side it is lateralizing. We have done Rinnes now to understand where there is air conduction problem, where there is bone. Now this is to confirm, Bing's and Gilles is to confirm that it is indeed an ossicular chain issue, conductive pathway issue, and not a cochlear issue. And the way we do it is Bing, I remember from the word finger, fing, bing, bing, fing, ping, bing. So the finger is placed here, closing the tragus, closing the external auditory canal, and opening, closing, opening, closing, opening. So you strike the tuning fork, place it on the mastoid, and keep closing, opening, closing, opening, closing, opening. You will see a variation in sound if there is a normal ossicular pathway. Why is there a variation in sound? Because when you close, the sound amplifies. When you open, the sound is coming from the air conduction pathway also. So there is at least a perceived fluctuation. But if there is an ossicular chain issue, there is otosclerosis or middle ear fluid, and there is no conduction of sound through the middle ear, then kitna bhi aap close kar lo, open kar lo, you are not going to see any difference at all, and that will confirm that this is conductive hearing loss. When a patient with otosclerosis, let us see, when the patient says I have right side, otosclerosis is bilateral, but sometimes it could be unilateral or it could be more on one side. So the patient says a right side conductive hearing loss, Weber's is lateralizing to the right in conductive hearing loss. In Rinnes is negative, bone conduction is better than air conduction. When you do absolute bone conduction, it is not prolonged, but 𝐶𝐶, it is prolonged on the right side. And when you do Bings, there is no change when you are changing the pressure. And then with this, you get a very good idea that yeah, what we are dealing with is some sort of ossicular fixation, ossicular chain problem, middle ear problem, because of which conductive hearing loss is not happening. Same test, instead of the finger, if you use a 𝐶𝐶𝐮 speculum, that like 𝐬𝐴's 𝐶𝐶𝐮. So I remember it that way: Bing finger, 𝐬𝐴's 𝐶𝐶𝐮. So that way I can know what it is. It's not a logical way to remember, but what is a rhyme hota hai, Bing fing and 𝐬𝐴's 𝐶𝐮. So with this, your pressure you are changing is through the 𝐶𝐶𝐮 speculum. You are increasing the pump, reducing the pump, and by doing that, you are able to get the sound fluctuations that are happening. And if there are no change, then again that means there is a middle ear problem, some conductive deafness is there. Stengers is the most interesting test. Do not read all these words that are put there. This is only put so that when you're going to revise, you can read it, but I will explain it to you, so don't look at that and listen to me over here. Stengers is when somebody is lying to you, somebody is malingering for internal benefit of some sort of certificate or some monetary benefit. लोग आके झूठ बोलते हैं and आपको वो झूठ पकड़ना है. तो आप क्या करोगे Stengers test में? In Stengers test, you have to blindfold the patient in full trust. And once the patient is blindfolded, you are basically going to use two tuning forks. The patient does not know that you are using two tuning forks, and that is how you trick the patient. If the patient is lying, if the patient is telling the truth, there is no trick. Patient will be honest and tell you what is happening. तो इसमें क्या करते हैं? That patient is blindfolded. You strike both the tuning forks, keep it at exactly equal distance. If you don't keep it at exactly equal distance, your test will fail. Exactly equal distance. Now suppose patient is saying right here ये नहीं सुनाई दे रहा है, and patient झूठ बोल रहा है, patient is lying. So now when you're doing this tuning fork test and you kept it equidistant, now the patient is able to hear both sounds, right, equally, because they're equally distant. But patient knows I'm lying, the right side पे तो सुनाई नहीं दे रहा. So what will patient say? Patient will say, I can only hear on the left side, doctor. I cannot hear on the right side at all. Like I told you, I am deaf on the right side. I need the certification for some benefits. You will be like, okay, fine, now I'm going to change something, now you tell me. And what I do now is I bring the tuning fork closer to the ear. Now he does not know whether I have removed the other side or whether it is still there. There is a principle that when the sound source is closer, it overshadows the sound that is coming from the other side. So what happens is now the patient thinks, acha, doctor has now brought it out completely close to my right ear, and he wants to check whether I have got the hearing problem or not. So what will the patient who's lying say? The patient who's lying will say, I cannot hear at all, right? And the patient does not know that there's a tuning fork on the other side because you bought it close, and wo pakada gaya. Because a person who has a normal left ear and is a genuine right ear hearing loss will say, doctor, I can still hear from the left side. That is how the Stengers test we kind of trick and catch. But this works better for unilateral claim. If somebody is claiming both sides, it's very hard to do this, because then he's going to say, I can't hear anything, whatever you do. Then what do you do in that case? Don't worry, we have very clever and smart doctors who preceded us, and they came up with another issue, another solution for it, called as a Lombard test. I remember Lombard by bombarding sound. So basically you give a headphones to a patient and you don't tell them anything about any music. You say we are just masking the sound outside, and sometimes you may hear some sound occasionally, and you ask them to read a book, or you ask them a question and listen to them talk. And while they least expect it, slowly increase the volume of the sound. And as you're increasing the volume of the sound, you will see that the person's reading volume or talking volume is also involuntarily increasing, and that will only happen if they are able to hear. And if they are not able to hear, they will not be able to increase their volume. They will say in the same tone, same volume, and not with any additional increase in sound. So Lombard's test is very, very difficult. Even if you practice very hard, as the sound gets louder and louder and louder, if you can hear it, how much ever good you are as an actor, you are going to be increasing your volume a little bit at least, to pick that up. And then that is the one that is going to has the catching and the punishment that follows, the screams which everybody will hear. All right. Then there is a pure tone audiometry. Pure tone audiometry is also a subjective test. Here basically an audiologist takes a patient into a soundproof room and gives sounds through a probe here, and puts a bone conduction system behind, and gives tones both in here as well as here. And we are measuring threshold. We are not measuring आप कितना ज़्यादा सुन सकते हो. We are measuring कितने नीचे से नीचे आप नहीं सुन सकते. What is the threshold below which you cannot hear anymore, and that is plotted. So if I am testing somebody's hearing, I will maybe give them a sound of 50 decibels, and then I'll slowly bring it down to 40, slowly bringing it down to 30, slowly bringing it down to 20, and try to find out where the person cannot hear. Where the person cannot hear, they lift their finger and say abhi sun nahi deta, and we put that on the graph. If it is the right ear, we put it in red. If it is left ear, we put it in blue for air conduction. If it is bone conduction, it is very simple. We use symbols which have openings on one side, right? So whichever direction is the opening, that is the side. So here is a bone conduction of the right side. Okay, this is the bone conduction of the left side, right? So we can use like this, or we can use like this. Whatever you use, it basically means that these symbols, which side the open end is, that is the side that it is. You can read the graph. Air bone gap less than 20, sensorineural hearing loss. If air bone gap is more than 20, then that basically means that there is some sort of conductive hearing loss. All right. Now patient says, doctor, I cannot hear also, I cannot talk also, I cannot watch also. क्या कर लोगे? अब दो मेरे को certificate. Then you go to some objective tests, and these objective tests are such tests where you really cannot have any say on the results. Okay, these are objective. This is a response of the body to sound, and if your inner hearing system is working, the response will be there. One of them is tympanometry or audiometry. It has a simple device, is a probe that goes inside, and that probe is basically doing three things. One is at 220 hertz, it's giving a tone through an oscillator. Uske baad it is changed. There's a pressure changing air pump that will change the pressure in the ear canal, and there's a microphone that will measure all the reflected sound that is coming from the drum. And now we plot it. Okay, so when we plot it on the y-axis, you measure compliance. Compliance matlab when I gave the sound, how much of that sound did the eardrum let it go inside the middle ear? Okay, how much of compliance was there? If there was too much of resistance, then what happens is the sound will get reflected back, right? But if the sound went through, okay, that is a compliance, because the drum through the ossicles, through the oval window foot plate, it is all going to go inside the fluid channel and system of the cochlea, and then the recoil of that, the scala tympani, is what is going to make the wave die. But if you don't do all of that sound is going to reflect back. So if more sound goes in, the higher the peak get. Less sound goes in, smaller the peak you get. Too much sound goes in, too much peak is formed. Compliance is in mmHOS. mmHOS is basically a measure of electrical conductivity or compliance, and this is pressure. Okay, zero इधर से minus आता है, and this way plus pressure आता है. So as you're increasing the pressure and decreasing the pressure, this is measured in DAPA, decipascal. Okay, so now think of it. Normal ear, you will see this very simple A-type curve. Okay, A-type curve, normal ear. Okay, now if there is a conductive issue where there is stiffness, there is otosclerosis, and the ossicles are not vibrating properly, then what will happen is a lot of the sound will get reflected back. You will have a very short or stunted AS, which is very classical of otosclerosis or any ossicular stiffening, ossicular fixation. If there is ossicular discontinuity, then you will see a very deep one. So that is called AD, very deep A curve, AD, and that basically also means discontinuity or ossicular discontinuity. Then if you get a flat curve like this, it is B, okay, B curve. That means there is some middle ear pathology, middle ear fluid. In this B curve also there are two types. There is a B high volume and there is a B normal or low volume. ये क्या है high volume, low volume? So here basically saying whether B curve is occurring when the ear canal is having an increased volume or a lesser volume. If the ear canal volume is increased, that means there is eardrum perforation and the canal, space is going all the way into the middle ear. So B curve with high canal, high volume, B curve basically means there is a tympanic membrane perforation. And if it is low volume, that means there is something in the ear canal. It could be wax, it could be foreign body, it could be any of those things. All right. And if there is negative pressure, then you need to increase the pressure, decrease the pressure so much to bring the peak that you will have a C-type curve, which is a negative pressure, which is patient tube blockage. That means the pressure is not equalizing. That's why you had to give negative pressure, to get that peak of sound or compliance. Only when that negative pressure equalizes the negative pressure in the middle ear is the compliance becoming possible. Otherwise, the sound is not going through. Right? I've written the same thing down over here for you to refer to and read. Don't worry, you will get this this particular notes. A is normal, AS is a shallow tympanogram like cirrhosis, AD is a deep tympanogram, and B flat I told you whether it is high volume or low volume. To measure high volume and low volume, normal volume is 0.6 to 2 centimeter cube, but if it is low volume it is going to be less than 0.3, and if it is high volume it is going to be more than 0.5. Right? Stapedial reflex is another thing. See, when you're going to give a sound signal, the sound signal is going to cause the stapedial muscle to contract to stop the excessive sound damage to happen inside the cochlea, and we call that a stapedial reflex. So we give a sound and then we look for these ossicular stiffening right after that, because that ossicular stiffening is going to happen only after the stapedial muscle contracts. If the stapedial muscle does not contract, then it is not going to control the stapes and stop the vibrations, and that you can make out by the tympanometric peak. So in otosclerosis or facial nerve palsy, you are not going to see any stapedial reflex. In Meniere's disease, it will be more sensitive and the threshold will keep dropping. It's getting more and more sensitive with lesser amount of sound. Very classical of Meniere's disease, because there's high pressure inside the cochlea, endolymph, and that's why slight amount of sound vibration is causing a lot of distortion and disturbance inside the cochlea, making it too sensitive. Right? Then OE is a very well recognized first point of care neonatal hearing screening system. It is basically capturing all the sounds coming inside the cochlea from the hair cells, outer hair cells, inner hair cells, and all of that, right? So it is basically picking all of those sounds, and that sounds are measured, and if those sounds are, you're not doing anything, you're just putting the probe and listening to the sounds, then that means this is spontaneous OAE. If you're going to give a sound, then that is called transient evoke. So transiently you're evoking it by giving some sort of a click or tone, and if you're giving more than one tone, then that is called a distortion product or two tones OAE. And if there's more than 30 decibel hearing loss or middle ear fluid, they will have decreased OAE response as well. Okay, so important thing. Now BERA is brainstem evoked response audiometry. Now this is like an ECG to see the sound path, then the electric impulses carrying from the cochlea all the way to the brain. You have 7 waves, 5 are the important ones, but you have to know the sequence. Okay, so first is of course inside the cochlea, which will be the spinal ganglion and the auditory nerve. All right, so that is the wave number 1. Then wave number 2 is the cochlear nucleus. After that it moves to the pons. The pons, how do you remember what it is? That is superior olivatory nucleus, where you can make PONS. Superior olivatory nucleus. Superior olivary nucleus also makes the word pons. That's how I remember it. But sometimes they give it as superior olivary complex, and then the situation becomes 𝐾𝐻𝐿. All right. but you get the idea. And after that, superior comes first to lateral बाजू में heart, that is the lateral meniscus. After that, there is the inferior colliculus, medial geniculate nucleus or medial geniculate body, and primary auditory. If there is any problem in the auditory pathway, typically you will see a problem in the second wave and the latency between the second and fifth wave. Because second wave tak to cochlea mein hai, but once it comes from cochlear nucleus and is going to traveling through the pons, if there is some acoustic neuroma or some other condition or cochlear demyelinating condition and all of that, these waves will not show properly. Now, how do you rehabilitate? You can give hearing aids. Hearing aids basically amplify sound in moderate to severe sensorineural hearing loss. Hearing aids का बहुत सारा stigma है, but I think with all of these new headphones which also look like ear the canal hearing aids, maybe these may improve with design. So there is one that is behind the ear one, which are like these, part of the processor. This goes inside the ear and this part is behind the ear. Okay, this is behind, this part is in the ear. All right, but then इसमें दिखता है, relevantly something is there, and people don't like that, right? So the other one is in the canal, ITC, in the canal. All right, so you can see it sitting here in the concha, but it is not completely in the canal. Completely in the canal ones are even more smaller, like these. Okay, these are completely in the canal, and they go completely inside the ear canal. You can't even make them out from outside. But the problem is, they are very limited, channels, the bands. So the way these amplifiers, they don't amplify every, decimal of frequency of sound. They do certain bands, just like how we have our radio frequencies, there are bands. Okay, so if I want to increase or amplify a frequency, I will amplify it from 200 to 400 hertz, and then 400 to 600 hertz. The smaller the band, the more expensive and the more complex it is, because then it is more specifically able to only amplify certain things. But some are only 4 channel, 6 channel. That means from 100 to 600 hertz sub amplify over. So then what happens is people start getting irritated, because even a sound which they do not want it to be amplified, they already can hear it, that is becoming to sound even more louder. So that's why you need 15 channel, 16 channel, 24 channels, as many as the maximum channels are possible, so that you have a better sensitivity to hearing aid usage. Then there is bone anchored hearing aid, which is trying to get its right of being an implant, but it is not an implant technically, because it's just a hearing aid that is having a titanium screw, and that screw is going into the skull just to hold it in place. It is not entering the cranial cavity or crossing the entire thickness of the skull. To be an implant, you need to be inside a body cavity, and just because this is just there stuck onto the skull is not considered as a hearing aid. This is a very popular question that was asked: which of the following are hearing aids? Which of the following are implants? All except, and bone anchored hearing aid was one of the option, and you would think ये तो implant होता है ना, titanium implant जाता है, and you didn't select that. But it is technically not an implant, and that is one of the important tricks that some of these examiners use, जो मैं आपको बता रहा हूँ. But anywhere where you cannot have this normal airway conduction pathway, that is where bone anchored hearing aids are used properly. Okay, so like for example, if somebody does not have ear canal at all, anoxia, microtia, or such chronic discharging ear, you can't give a hearing aid. You have atresia, keratosis obturans, otosclerosis, all of these conditions, you can give the same system of a hearing aid. This is less visible, because hair se cover ho jata hai, there is nothing that's there in the ear, and this is directly causing bone conduction, but it's very expensive, by lakhs device. But it is definitely useful in children who do not have the external ear system, and they have to also catch up with their speech. Cochlear implant, very popular nowadays, is a government program also. We are developing it by the government, and many programs are using it. Cochlear implant is an implant because here not only just one part is stuck here onto the skull, but there's an actual electrode implanted inside the cochlea through the round window, through the facial recess. So what we do is we drill the mastoid, we go into the facial recess, which is lateral to the pyramid. We find the round window there, then we pass the electrode, which has about 12 to 24 arrays. each array is stimulating a different set of the cochlea. It's a lot more specific than hearing aids, and then you are able to amplify sound. Sounds don't sound like how we hear it, but by proper training they're able to understand these sounds, learn these sounds again, and then they're able to treat or carry out their daily activity. Okay, so this is the cochlear implant. Indications for cochlear implant, lot of points over here just for your reference. Okay, earlier it used to be very confusing, prelingual, postlingually deaf, कब कराने का है, 1 साल के पहले, 1 साल के बाद, 1 महीने के अंदर. Now it has become very simple. Anybody with any profound hearing loss can, with a functioning cochlea, can be using a cochlear implant. All right, so you're bypassing the entire conductive pathway. You are directly triggering the cochlea by passing an electrode inside. Bilateral profound hearing loss, unilateral profound hearing loss, one side hearing loss, we're using cochlear implant, other side using hearing aid, bimodal treatment. If it's congenital hearing loss, baby is born deaf, then within the first year, 10 to 12 months, it is advisable. The speech develops after that. And if it is acquired hearing loss, there is no age limit. And if this hearing loss is predominantly low frequency, then the electrode does not really reach the apex. Okay, transmits the high frequency notes. So, and hearing loss associated with meningitis, labyrinthitis, and trauma. So important early complications are that there will be facial palsy and electrode displacement. Okay, so that's why there is a little ball there which is there to help us find radiographically where it is, and even in the surgical field find it. Ball also gets displaced sometimes, but it's like a grounding wire. Brain stem implant, ये काहे करेंगे? If the pathology is retrocochlear, behind the cochlea, तब क्या करोगे? Now भी middle ear काम नहीं कर रहा है, so then you take the electrodes and you put it inside the cochlea, but cochlea काम नहीं कर रहा है, then what will you do with these arrays? So as you can see in this image over here, that with this arrow, that instead it's the rest of the device is very same or similar, but instead of this going inside the cochlea, this is introduced directly inside the brain stem here, right? Inside the brain stem. All right, so what are the indications? If there is acoustic neuroma, there is a congenital cochlear demyelinating nerve disease or neurofibromatosis 2, then all of these you cannot use cochlear implants. It's a retrocochlear pathway and you have to directly trigger the brain stem pons, and that is why a brain stem implant, which is very expensive but can be helpful to people who have this particular problem, right? So that, guys, I hope this was useful for you. Audiology, I'm trying to make it simple so that you can quickly access and understand the very basics. You don't have to learn by heart. Audiology is very straightforward, very mathematical. अगर आपको concept समझ में आता है, any question, if you follow the right process of first identifying the side of the hearing loss, then do Weber's, then do Rinnes, then do the bone conduction, absolute bone conduction test, do the conductive hearing loss test, and then of course objective tests to figure out and confirm. Also, if somebody is lying to you, how will you tell by Stengers and Lombards that is the issue, and how do you rehabilitate with hearing aids, with cochlear implants, with brainstem implants? All right, if you have any questions related to this, please feel free to put them in the comment section and I will definitely get back to you and all your questions. Then guys, take care, bye bye, signing out.